Namaskar, welcome to PK's classes. Today we'll study the anticholinergic drugs used in asthma or chronic obstructive pulmonary disease COPD. Anticholinergic drugs or antimuscarinic drugs, the short-acting antimuscarinic drugs, LAMA, and long-acting antimuscarinic drugs, LAMA. So chronic obstructive pulmonary disease and bronchial asthma are characterized by bronchospasm and bronchial inflammation, and bronchial smooth muscles are innervated by cholinergic neurons, parasympathetic nerves. There is no sympathetic innervation, only parasympathetic innervation is there. So acetylcholine acts on the muscarinic receptor M3 cholinergic receptor to cause bronchoconstriction. So the mechanism of bronchial smooth muscles contraction is calcium mediated. So calcium binds with a cytosolic protein called calmodulin to form calcium calmodulin complex, and calcium calmodulin complex activates the enzyme myosin light chain kinase, and the active myosin light chain kinase phosphorylates myosin. Now this phosphorylated myosin gets energy to bind with actin to cause contraction of bronchial smooth muscles or bronchospasm. So acetylcholine, by binding to M3 receptor, releases calcium. So M3 receptor is a GQ type G protein coupled receptor where the effector is phospholipase C beta, and the phospholipase C beta is activated, which converts phosphatidyl inositol diphosphate PIP2 into two products. One is inositol triphosphate IP3 and the other is diacyl glycerol. IP3 acts on the calcium stores in the endoplasmic reticulum to release calcium. Now this calcium binds with calmodulin and causes bronchial smooth muscle contraction. The second mechanism is mediated by diacyl glycerol. Diacyl glycerol DAG activates the enzyme protein kinase C, which activates calponin by phosphorylating it, and calponin actually inhibits the dephosphorylation of myosin phosphate to myosin. So this is inhibited by calponin, and since it inhibits the dephosphorylation, there will be myosin phosphate available, and this myosin phosphate binds with actin and causes contraction. So two pathways, one is IP3 mediated and the other is DAG mediated, and in both the pathways there is phosphorylation of myosin, and now that myosin binds with actin to cause contraction of bronchial smooth muscles. So we can use anticholinergic drug, that is antimuscarinic drug, which is M3 receptor blocker. And you can see here, normally the vagus nerve is supplied the cholinergic neuron, and acetylcholine is released, causes contraction of the bronchial smooth muscles. And you can see here in COPD there is bronchoconstriction as compared to this normal, there is bronchoconstriction. This is bronchoconstriction. So when we use anticholinergic drug, there will be bronchodilation in normal as well as in COPD, but in normal it is a small bronchodilation, whereas in asthmatic patient or in COPD patients it is greater bronchodilation as compared to this one. So it is COPD patients bronchoconstriction, and after giving anticholinergic drug, this is bronchodilation. So anticholinergic drugs or antimuscarinic drugs can be either short-acting or long-acting. Short-acting antimuscarinic drugs, LAMA; long-acting antimuscarinic drugs, LAMA. So SAMA, example, Ipratropium, acetylcholine, and long-acting antimuscarinic drugs, tiotropium, aclidinium, mAChRs, glycopyrrolate. So they act by blocking the muscarinic receptors, and they are given by inhalation, aerosols. They have delayed onset of action. They are actually the quaternary derivatives of atropine, so they are polar in nature. They does not diffuse into the blood, do not enter central nervous system, so they have minimal systemic side effects. So their route of administration is inhalational, and they can be of two types: short-acting, where the duration of action is 3 to 5 hours, example Ipratropium, and long-acting duration of action is 24 hours, example is tiotropium. So they can be used in treatment of COPD mainly as a standard treatment for COPD, and they can be used as adjunctive therapy in severe asthma in combination with the beta 2 agonist or corticosteroids, and the antimuscarinic drugs can also be used in rhinorrhea, a runny nose caused by allergies or colds. So the combinations used, there can be combination of a short-acting antimuscarinic drug like Ipratropium with a short-acting beta 2 agonist like salbutamol. But combination therapy of short-acting beta 2 agonist and short-acting antimuscarinic drug is reported to show a faster onset of action and greater peak bronchodilation as compared to long-acting antimuscarinic drugs and long-acting beta 2 agonists. So the long-acting antimuscarinic drugs are usually used as monotherapy. The long-acting beta 2 agonists are also used as monotherapy, but when the monotherapy is ineffective, the combination of long-acting antimuscarinic drug and long-acting beta 2 agonist are used. For example, tiotropium plus olodaterol, tiotropium plus carmoterol, tiotropium plus formoterol, glycopyrrolate plus indacaterol, mAChRs plus vilanterol, and when the combination therapy, the dual therapy is ineffective, then we can use three combinations: inhaled corticosteroids like sidesonide, budesonide, the inhaled corticosteroids ICS are usually used in combination with the LAMA and LABA for patients with chronic obstructive pulmonary disease, particularly in patients with a higher risk of exacerbations. So this is all about the SAMA, short-acting antimuscarinic drugs, and long-acting antimuscarinic drugs. And if we compare the short-acting antimuscarinic drug and long-acting antimuscarinic drug, short-acting antimuscarinic drugs is often a short-acting reliever medication actually, and they are not typically used for long-term maintenance therapy in COPD. For long-term maintenance therapy, we need long-acting antimuscarinic drugs. Short-acting antimuscarinic drugs are only used as reliever medications for acute symptoms of COPD. For example, this Ipratropium. So this is all about the antimuscarinic drugs used in COPD and bronchial asthma. Thank you.